Support for this podcast comes from Bryn Mawr Communications. BMC produces a number of informative podcast series spanning a variety of topics in ophthalmology. Discover a new show at itube.net/podcasts.
Welcome to Pupil Pod, where we use clinical cases to guide discussions on board review topics. I'm your host, Ogul Uner, and my guest today is a dear mentor, colleague, friend, and podcast extraordinaire, Dr. Amanda Redfern. Dr. Redfern is a board-certified neuro-ophthalmologist at KCI Institute of Oregon Health and Science University in Portland, Oregon, and I'm so excited to have her on our podcast today as a guest. Dr. Redfern, thank you again for joining me.
Oh, thank you so much, Ol, for having me. I feel very honored.
Oh, great. Let's start our case. We have a 70-year-old woman who is coming to your clinic with intermittent grayouts in her right eye. She reports an ongoing headache in the past 2 weeks, along with feeling sick and not really eating much. She has a history of hypertension that's well controlled on amlodipine. She has no prior ocular history. Visual acuity is 20/60 in that affected right eye and 20/20 in the left eye, with a relative afferent pupillary defect in the right eye. Intraocular pressure is normal, extraocular movements are full, and confrontational visual fields are also full. The anterior segment is only remarkable for cataracts in both eyes. On the posterior segment exam, there's 360 blurring of the optic disc margin without vessel obscuration and peripapillary cotton wool spots in the right eye, as well as a normal appearing left optic disc with a cup to disc ratio of 0.4. Dr. Redfern, what are your thoughts about this case and what additional information would you like to know?
Well, the first thing I think about when I hear that an optic nerve is swollen is there an optic neuropathy with it or is there not? And fortunately, you already answered that for me because you have the decreased visual acuity with an RAPD. So you have a very objective finding that this is accompanied by a true optic neuropathy. And so with her prodrome of having these episodes of intermittent blackouts of the vision to this time point now that we're seeing her where she has that vision loss, I'm really, really worried about an arteritic anterior ischemic optic neuropathy in particular in this case. Um, of course, anytime you bring up arteritic, you're going to want to do a full review of systems. Part of it you've already given me here, but I want a little bit more history about fevers, chills, unexpected weight loss, new arthralgias, particularly in the shoulders or hips, or past medical history of PMR. Of course, jaw claudication, any scalp tenderness, new headaches. Do you have like a cord on your forehead? Not that people really pay attention to that, but we might pay attention to that when we're looking at the patient. And new rashes, but generally signs of, either arteritis or inflammatory disease in their history. And then in terms of what we can do more in the office to better understand what's going on is get additional testing. And so for me, I always get a visual field for someone who has an acute vision loss. It's really helpful, especially if you have some classic visual field defect, although all bets are off to me when it comes to AAION. But certainly, like an altitudinal vision loss really sends you down that ischemic optic neuropathy pathway. I typically also get an OCT for a few reasons. One, I want to make sure I'm not missing other pathology that goes along with it, like maybe my retina exam is not as good as Dr. Uner's, but I do my best. And there are some things that are hard to see with the naked eye. So I always look for that. And certain findings on it can be more suggestive of AAION, such as seeing PAM or like a hyperreflectivity in the middle layers of the retina. And then very classically, you could get a fluorescein angiogram. I think that's kind of dependent on where you practice and what's available to you. Certainly, if you're in a place where they have that available and technicians who can readily do that, that's something that can be very helpful because you're looking for that choroidal ischemia, especially very patchy choroidal ischemia. For me, it's really hard for me to get at my office. It's kinda dependent on how busy our techs our imaging staff are that day. So I don't always get it, or sometimes I only get it as a tiebreaker when I'm really sitting on the fence. But that would be a very, helpful thing to get if you have easy access to it.
I think you covered a lot of different findings that we would potentially see, and we'll come back to the case towards the end of our talk. But I want to direct us more towards the anterior ischemic optic neuropathy that you mentioned. So, what is anterior ischemic optic neuropathy, and how do you categorize it in your head?
Great question. So, the basic spiel I actually give my patients is an optic neuropathy is very simply damage to the optic nerve. Ischemic means that there's been poor blood flow to that optic nerve, and anterior means that the optic nerve head itself is involved. And that's the only part we can actually see on our exam. So if that optic nerve head is not swollen, it is not anterior ischemic optic neuropathy. That optic nerve head has to be involved for it to be an anterior ischemic optic neuropathy. And then there are kind of two flavors to this. There's arteritic and non-arteritic. And we could talk about that now, or we could save that for later.
So, you mentioned arteritic anterior ischemic optic neuropathy, or AAION. What is the classic demographic of the patients that present with this condition, and what symptoms do they come into our office for?
So, very classically, they're the little old white lady. Um, and when I say old, like 70s to 80s, uh, certainly it happened. Any like race can be affected, and certainly men are affected. And I have male patients too. But I was reflecting as we're prepping for this podcast. I'm like, yeah, all of my recent ones have been little old white ladies, and perhaps it's the demographic I deal with because I do live in Oregon. But yeah, that is the classic. And then in terms of the other ways they might present, you already kind of talked about one. She started off this way: transient monocular vision loss, or amaurosis fugax. Is a very classic presentation. And certainly, if you see someone like that, you want to be thinking about GCA. But other ways they might present is like a cranial nerve palsy. That can also be arteritic. They can present with choroidal ischemia only and have just really, really odd visual symptoms. Like I had one lady whose only complaint in our office was like these bright white lights in her vision. And I was not convinced it was anything and was absolutely floored when it turned out to be GCA eventually and her symptoms from the choroidal ischemia. They can also present with a central retinal artery occlusion or a ciliary uh, retinal artery occlusion. It should not be a branch retinal artery occlusion because we really think of this as being, we think of this disease as affecting the short posterior ciliary arteries. And so that's why the ciliary retinal artery occlusion is the exception to the branch retinal artery occlusion rule.
You really highlighted the diversity of presentations there, and the diversity of the exam features that we can see. It's not always the classic pallid disc edema that is evident on our books and our exams. Yes, you can see disc edema, you can see peripapillary hemorrhages, but it's really important to do a full exam in these patients to make sure we're not missing other maybe subtle manifestations of the disease. So you mentioned some of these imaging tests in the beginning, but what are some typical imaging tests that you obtain at baseline for patients you suspect have giant cell arteritis or AAION, and how do you monitor these patients long term?
Visual field and OCT for sure. You are talking to a neuro-ophthalmologist. FA, if they're having a really weird visual symptom like that one lady I just talked about, I might try to arrange for an FA that day or having her come back for it if I really can't find a good explanation, and just to use that as a tool to look for choroidal ischemia. I actually don't monitor these patients typically. If I ultimately diagnose them with giant cell arteritis, that's actually a rheumatologic disease and is managed by a rheumatologist. Um, I don't expect me having them come in to do these tests will in any way, shape, or form change their outcome or change their clinical management at that point. And so I often don't bring them back for monitoring once they're on the right track. I do keep a close eye on them and have them return until I'm sure that they're connected and not going to fall through the cracks.
That makes sense. And speaking of the systemic involvement, what is your general workup when you see a patient who you suspect has this? Do you send everybody to the emergency room? Do you get magnetic resonance imaging of the brain or orbits in some patients? How do you think about your overall workup and the urgency of it?
It really depends on how certain I am this is AAION. The typical workup is going to be your ESR, CRP, CBC, and you're looking for elevated inflammatory markers, the thrombocytosis as well, like a reactive thrombocytosis in an inflammatory state. And, if I am really certain this is AAON, like they present with pallid disc edema and they have a review of systems that is positive for cranial symptoms, like they have jaw claudication, that's a ticket to the ER and getting IV Solumedrol 1 gram a day for 3 days. Um, if it is and that's also gonna be a patient that I don't care what your inflammatory markers are. This is GCA period, even if for some reason those markers come back negative, which they probably won't. If it is someone that I'm hedging where they have um, what could very well be non-arteritic anterior ischemic optic neuropathy or NAION. That's someone where I would have them get the labs on their way out, lab across the street, or if it's end of day, here's the lab orders, take it to your local lab first thing tomorrow. And then if the inflammatory markers are positive, then I would go ahead and have them start prednisone, usually a mg per kg per day. I might cap it at 60 though if they're really old because I get a little bit nervous about putting 80-year-olds on high doses of steroids. I probably would cap it at 60 milligrams. So I would have them take that dose until they got the temporal artery biopsy done and until those results were in my hand. And then if they're positive, they continue on that dose until they see the rheumatologist. If it's negative, then I taper them off of it.
And that is a great segue to my next question, which you have a patient who have elevated inflammatory markers. You said that you would schedule a temporal artery biopsy. What is a temporal artery biopsy, and what is the urgency of scheduling it when you start corticosteroids? Is there a specific time frame you would want the tab done?
A temporal artery biopsy is exactly what it sounds like. We're taking a biopsy of this superficial temporal artery. It's generally a well tolerated procedure room kind of thing, not necessarily going to an OR unless they have some extreme anxiety and need to be knocked out for it. But it's done, under local in an office in a controlled setting. You try to get as much of that temporal artery as you can. At least 2 centimeters is like the goal, but the more the better. And then that's sent off to a pathologist who does ideally very, very thin slices and takes a look at all those very thin slices to look for inflammation in the temporal artery and specifically giant cells, which is where the name giant cell arteritis comes from.
And what is the urgency of obtaining a tab after you start corticosteroids?
The classic teaching, at least when I was in residency, was you want to get it done within 2 weeks of starting steroids. Sooner the better, because the longer you're on steroids, the more the inflammation comes down, and you might miss seeing those giant cells. However, in reality, I would say just get it done as fast as you can. There are going to be barriers to care, finding someone, a surgeon who's willing to do it for you, insurance issues, but the sooner the better because they can still look for evidence of past inflammation, things that shouldn't be there, like damage to the elastic lamina.
You mentioned that a pathologist is really important to be involved. What is the percentage of positive cases that we see within a pathology specimen? You mentioned that it's important to get 2 centimeters, but do we see giant cells in all the cases? Is there worth doing a second biopsy if a first biopsy is negative? And what are maybe some stains that the pathologist can use to highlight other features of the inflammation that might be present in the specimen?
So, depending on which papers or series you read, you'll get different percentages, but I think classically we think of it being a generally low yield, so about 50% sensitivity with one biopsy. And if you're really certain or you're really suspicious, you can definitely go back and get the second temporal artery, or if you really think that this is our one chance and the patient's only going to go for this one, sometimes I do go for a bilateral temporal artery biopsy just to get more specimen to evaluate for this disease when we know it is active and showing its face right now. You can go back and get a second biopsy, and that may be helpful. Things that I would ask the pathologist to look for, and I have to credit Dr. Prospero Ponce. She's a neuro-ophthalmologist and ocular pathologist. So I had a great discussion with her, and she had talked about what every pathologist needs to do when they get these samples is to do a CD68 stain to highlight macrophages and any stain to highlight the elastic lamina. And what you're really looking for is macrophages at the level of the elastic lamina because that can be a really good marker for uh, temporal arteritis, even in the absence of giant cells, because they shouldn't be hanging out in that spot. That is, they should be in the lumen of the vessel. They should not. They have no business being near the elastic lamina and disruption of the elastic lamina. Like they should not be chewing up your elastic lamina. That's not okay. Not normal under any circumstance. And then, if that person has been on steroids for a while, there may not be signs of inflammatory cells there, but the once an elastic lamina is, as one says, chewed up by the macrophages, um, it doesn't repair itself. So you see the evidence of the disruption there. And without any other signs like calcification that suggest some other pathology, that would be suggestive of giant cell arteritis.
I think those are great points to highlight. I recall my own pathology rotation and residency, where we would get several temporal artery biopsy specimens, and sometimes it would be really difficult to distinguish atherosclerotic disease and changes related to that, which is also highly prevalent in this patient population, um, and some features of possible chronic inflammation related to that versus inflammation that's directly related to giant cell arteritis. So, thank you for highlighting some of those stains. And looking forward for the visual prognosis, when you diagnose a patient with arteritic AAION or giant cell arteritis, what do you talk about in terms of their visual prognosis and maybe their long-term treatment? What is maybe some treatment that rheumatologists can use long-term after their prednisone course?
Great question. So, you know, AAON in general tends to be quite devastating. And unfortunately, I do not expect our treatment to improve the vision in the affected eye. The point of us bombing these patients with steroids is actually to get that inflammation down so the other eye doesn't get affected. I mean, it would be great if you get some vision back. In my experience, I haven't seen that yet. I know there are percentages quoted in the literature, but I like really have not seen that personally. And I think especially in AAON as opposed to NAON, we really are not very optimistic for the eye affected, and we're trying to save the good eye. In terms of the long-term treatment outlook, if you do have giant cell arteritis, then you really need to be on something to control that inflammation so it doesn't affect the other eye or other parts of your body, right? Like, you can die from giant cell arteritis, and we need to get that inflammation down before something like that happens. And so typically in the old days, you would just stay on steroids for a very long time. There's this standard taper that they used to do that was also guided by repeat tests of your inflammatory markers. So if every time you pass that test where your inflammatory markers were normal, and then we tapered a little bit and they test again, even the best case scenario, that taper is like a year and a half long. It's like super miserable, especially for the patients who don't like steroids. There's some who love it, but most people don't like being on chronic steroids. And what's really awesome is that there is a drug called tocilizumab that rheumatologists are now able to offer our patients, and it helps in a very steroid sparing way control the disease. And so we found that using tocilizumab has been able to help people either wean completely off of the steroids or get down to a much more manageable level much sooner in the disease course. Always get your patients to a rheumatologist ASAP.
That's great. And I think that's a very important message, especially for this disease. So let's summarize what we learned from Dr. Redfern. Ischemic optic neuropathy occurs when there's loss of blood flow to the optic nerve. And depending on which segment of the optic nerve is affected, it's classified as either anterior ischemic optic neuropathy or AION, or posterior. Within AION, we have NAION or non-arteritic anterior ischemic optic neuropathy, or arteritic anterior ischemic optic neuropathy, or AION. AION, in general, the anterior ischemic optic neuropathy groups accounts for 90% of all ischemic optic neuropathies, and is the most common optic neuropathy in patients older than 50 years old. Always think about the arteritic cause, which is the GCA variant. When you see a patient over the age of 50 that has headaches, diplopia, jaw claudication, scalp tenderness, malaise, fever, weight loss, and intermittent vision loss. Keep in mind, however, that up to 25% of patients with vision loss from GCA do not have any systemic symptoms. So important to maintain high suspicion for patients in this age group. These patients need urgent ESR-CRP and CBC to look for the inflammatory markers and the platelet count. And importance of systemic corticosteroids, either in IV or oral form, and a temporal artery biopsy, ideally scheduled within 2 weeks of initiating steroids. Don't forget to obtain at least 2 centimeters of the temporal artery for your friendly pathologist, who will be looking for giant cells or mononuclear cells like lymphocytes or macrophages within the vessel walls, or the CD68 stain to highlight these cells at the level of the elastic lamina, or other stains to highlight the elastic lamina to look for breaks. Tocilizumab is an FDA-approved medicine that comes in injectable and IV form that can be used long-term for this condition. And it's important that this patient sees a rheumatologist as soon as possible so that they can establish and have them follow their disease and their other systemic manifestations. Dr. Redfern, anything else you would like to add?
That was a great summary. I have nothing more to add. You can now take over my clinic for me, Dr. Uner.
I could never do that, but I appreciate the sentiment. But Dr. Redfern, before we end each episode, I ask all of my guests a question, and my question for you is: if you could go back in time and give your younger self one piece of advice, what would it be?
Stay open-minded about your future career. Don't have everything planned out, set in stone. Say yes to opportunities and see where they lead you, because I can say that my career today is nothing like I had imagined it back when I was a med student and applying into ophthalmology. It is nothing like I imagined it when I was in ophthalmology and applying into fellowship. And it's actually nothing like I imagined it when I was in fellowship and applying for this job. But my career has been shaped by the pursuit of multiple new experiences, and I am so glad that I just went with the flow.
That's great. That's very inspirational and really highlights the importance of, as you said, just going with the flow and saying yes to opportunities. And I think that's a great reminder for all of us. So thank you so much for that answer. And Dr. Redfern, thank you so much for joining us on this episode of the Pupil Pod.
Thanks for having me.
And thank you to our listeners. See you next time on the Pupil Pod.